Hello, everyone. This is Lukman Yusuf speaking. I am the campaign manager for the Global Green and Healthy Hospital Africa Network, and I'm delighted to welcome all of you today for the first series of webinar from Africa on reducing unintended persistent organic pollutants and mercury releases from the healthcare sector in Africa. This is a project being implemented by the United Nations Development Program, Istanbul Regional Hub, in partnership with the World Health Organization and Healthcare Without Harm, and which is supported by our strategic partner in Africa, Groundwork. The aim of this project is actually to promote best practices and techniques for healthcare waste management with the aim of minimizing and eliminating releases of persistent organic pollutants, and also to help these countries meet their obligations under the Stockholm Convention. The second objective is also to support these countries in facing down the use of mercury-containing medical devices, such as thermometers and blood pressure devices, while also improving practices for mercury-containing waste. And finally, because this project is aimed at improving healthcare waste management, we hope to also contribute to the reduction of the spread of infectious diseases in healthcare facilities at facility level, as well as places where healthcare waste is being handled. I'm joined here today with the coordinators, the national project coordinators who are implementing this project in Zambia and Ghana, and they will be presenting to us today and giving us a situation and report back analysis of where they are currently. From Ghana, I'm joined with by Ms. Abena Nakawa. Abena has 8 years of experience in environmental management with expertise in disaster risk reduction, climate change, and livelihood empowerment. She currently holds a Master of Arts degree in environmental security and livelihood change from the University for Development Studies in Ghana. And she's currently holding the position of the National Project Coordinator for this project in Ghana. Also from Zambia is Mr. Mwape Nkandu, who has over 20 years of experience working with both government and non-governmental organizations on issues relating to environmental regulation and enforcement. He holds a master's degree in environmental studies and is currently National Project Coordinator for this project in Zambia. I would like to give the floor now to Ms. Abena Nakawa for the first presentation. But first, I would just like to inform all the audience here that we have a chat box just at the bottom right corner. You can put your questions in there during the presentation. Abena, the floor is open to you now.
Okay, thank you, Lukman. Since I've already been introduced, I won't bore us with all that. We'll just go straight to the presentation. So the outline of the presentation is that will give you a brief detail of the project, the background of the project objectives and goals. Lukman has already mentioned a few, and then we would zero into the Ghana situation and then how far we have come in terms of project implementation. So the project is a global environmental facility funded project. It's a regional project involving 4 countries, Ghana, Tanzania, Madagascar, and Zambia. The Ghana component is implemented by the Ministry of Health and its implementing agency, which is the Ghana Health Service. And then for the project implementation, it is done both at the regional level and then at the national level. This means that some activities are taken up at the regional hub, which is the Istanbul Regional Hub, and then countries also have specific activities that they would undertake at their level. So for the background of the project, the project has been developed as a result of the rapid increase of the generation of healthcare waste in Ghana. This is as a result of governments work to provide access to healthcare delivery to all corners of the country. By that, the country healthcare delivery is done in zones where we have a project called Community Health Infrastructure Project, which is popularly known as CHIP compound. So healthcare delivery points are spreading in the country so that citizens will have access to healthcare services. And then also, it's also as a result of poor segregation practices at the facility levels. The project is also as a result of to reduce the spread of HIV and then AIDS and other infectious diseases from healthcare waste. We are aware that patients with with HIV and AIDS have to be dealt with in a very special way. Their mode of care, how the patient, him or herself, is cared for, the instruments that are used to care for the patient needs to be well handled in order to prevent the spread of the disease to other places. Again, we have an increase in healthcare waste generation as a result of immunization campaigns. This is due to education and then the awareness creation that has gone on, and the fact that people have embraced immunization of their children. So healthcare delivery these days generates a lot of waste. And as a result, in Ghana, we have managed to work on how to manage the healthcare waste that we generate from delivering these services. But as it's seen there, it's through incineration at very low temperatures, which produces dioxins and furans and other toxic pollutants. Again, the project has been developed because Ghana is signatory to the Stockholm Convention on POPs. POPs is persistent organic pollutants. And as a signatory, we seek to eliminate the production and use of intentionally and unintentionally produced persistent organic pollutants where possible. And then also, as a result of incineration of the health waste at low temperatures, there is a production of dioxins and furans and other toxic air pollutants which affect the health when humans are exposed to it. Their health is affected. In the long term, low-level exposures of humans to dioxins and furans may lead to the impairment of the immune system, the impairment of the development of the nervous system and the endocrine system, and then the reproductive system. In short term, high-level exposure may result in skin lesions and altered liver functions. Exposure, even animals can also be affected when they are exposed to dioxins and then furan emissions, causing some cancer. The project will also be working as part of Ghana's obligation towards the Minamata Convention, which we have ratified. The convention is an international treaty designed to protect human health and the environment from anthropogenic emissions and releases of mercury and mercury components. We know that in the health sector, the use of mercury, though in small quantities, can also, when there are problems with the instruments which contain the mercury, it means that there will be an exposure into the environment, and there is a likelihood of its adverse effects on humans when they are exposed. For example, mercury and its related compounds can affect the kidney, brain development in children, central nervous system, etc. Release of mercury can be reduced through the phase-out of mercury-containing devices in the health facilities. As Lukman mentioned, the objective of the project is to work with the healthcare sectors in Ghana, Madagascar, Tanzania, and Zambia to, first of all, implement best environmental practices in the health sector. The health sector, it has been realized through the Libreville Declaration that there is a link between the environment and health. So there is a need for the health sector to also play its role in terms of best environmental practices to reduce all the effects all the health risks that it may generate. The project will also introduce non-incineration and mercury-free technologies. Non-incineration, like I mentioned earlier, in Ghana, currently, the means of managing healthcare waste is by incineration. Sometimes in some facilities with the demon front incinerator, and that is mostly used to manage sharps. And then there is also in very deprived areas, you can even have open burning of some healthcare waste. The project also was to ensure the availability and affordability of non-incineration waste treatment technologies in the region. Okay, so in Ghana, currently, healthcare waste, these are some of the ways that we are managing the waste that we generate in the facilities. For some pathological waste, like the placenta, we have pits where they are put in there and then some amount of chlorine added and then waited for decomposition. In some areas also, we have sharp pits where these sharps, mostly in the rural areas, these sharps are buried after use. For radioactive waste, it is managed, because of its nature, it is managed by another agency in the country known as the Ghana Atomic and Nuclear Authority. Pharmaceutical waste is handled by the Environmental Protection Agency, and then, like I said previously, in areas where you don't have Environmental Protection Agency offices, then these are buried at dump sites. There is a policy and a guideline on healthcare waste management, which was developed in 2006 to support the offices and all stakeholders involved in healthcare waste management. Just this past year, the Environmental Protection Agency has also developed what we call the Hazardous Waste Act 2016, where there is a section on how healthcare waste should be managed in the country. Due to the fact that there is generally a lack of sector-wide management system, most health facilities have adopted their own way of managing their waste, as I've already mentioned. Again, at most of the facilities, there are no specific officers or trained staff to handle healthcare waste. What they have in there are normally occupational and health safety officers who take up the duties of healthcare waste management. And then also sometimes it's the infection prevention control officers who do this. And as a result of that, healthcare waste management is not very topical issues. It's treated as subheadings under these two major headings. In recent times, new facilities, though a lot of education has gone on, we have seen that technologies are being developed and all that. So new facilities have now started installing non-incineration facilities like autoclaves and hydroclaves for healthcare waste treatment. And then also most facilities are still using the mercury-containing BP apparatus, with a few of them using mercury thermometers. The thermometer education, I think, has gone down very well than the BP apparatus, because the health staff are a bit antagonistic in the use of the BP apparatus because of the complaints that they give Some of them say that it doesn't give the correct readings that they want if they have to use the digital or Android apparatus. Okay. So how has this project reducing UPOPs and mercury in the health sector in Africa helped in this situation that Ghana finds itself? So far, the project has started in February last year, and then so far, these are the interventions that we have put in place to change the face of healthcare waste management in the country. 4 national experts and participating institutions have had a capacity building section, and some of the topics that they were trained in include healthcare waste strategies, how to develop healthcare waste strategies and policies, action plans, and also how to develop standards and guidelines, first of all at the national level and then also at the facility level to manage healthcare waste. Again, the project is working with the School of Hygiene. The School of Hygiene is the main institution in the country that trains environmental health officers. These officers, first of all, when they are trained, are released to the Ministry of Local Government and Rural Development, and then they are linked to hospitals to help them with the management of their waste. So the project has worked with the responsible tutors and departments of the School of Hygiene, particularly in Accra. There are about 2 of them. The one in Accra, we have liaised with the department and tutor responsible to update the curriculum for environmental health studies to include healthcare waste management as a main topic, so that it is not discussed as a subtopic of all other issues relating to occupational health and safety and environment and all that, but so that healthcare waste, as time goes on, can become a major topic where people can go and read the course and then have expertise in managing these wastes, so that our facilities will be equipped with professionals who can help us to manage the waste. Again, we noticed that before the inception of the project, the baseline report makes us know that there is inadequate infrastructure, and then most of the facilities are lacking in terms of the necessary logistics and administrative issues to put in place a health care waste management system. So what this project has done is that we want to use some facilities as model facilities to put in place these healthcare waste systems, and then for other facilities to look on, and then also for government to do a scale up after the project. So what we are doing is that we have selected 2 main regional hospitals to serve as model facilities for a cluster treatment technology. Cluster treatment technology is where there is a non-incineration equipment at one of the in both facilities, and then healthcare facilities around those. The main one bring in their waste, especially the infectious part of their waste, to these facilities for treatment. And then because we are trying to establish a system where healthcare waste facilities treat their waste before disposal, we are also trying to demonstrate that at various levels. So apart from the regional facility, we also have a health center that is like a health post in a very small community, who will be doing an on-site treatment. On-site treatment is that that facility would have to be treating its own infectious waste before disposal. So we have selected 3 main hospitals. One is a teaching hospital, the other is a regional hospital, and then the healthcare facility, the healthcare center, sorry, to demonstrate the health systems that we are kind of recommending to the health sector to put in place. Okay, so what the project has done with the national policy and regulatory framework. First of all, before we go to the ground implementation of the systems, the project encourages us to strengthen what is already existing in terms of national policy and regulation. So what we have done in the past year is to revise the Ministry of Health Policy and Guideline for Healthcare Waste Management, which was developed in 2006. What is different about this revised policy is that with this one, we have incorporated most of the international conventions that Ghana has signed on to. For example, the Minamata Convention, the Libreville Convention, the Bamako Convention. We have also put in there some policy areas to address the SDGs which are related to healthcare waste management, SDG, I think 6, 12, 16, and another one. Then also, what is also different with this revised policy is that the previous policy had the policy and the national guideline together. In that instance, we missed the target groups that each one of these documents is supposed to be addressing. So what we have done is that instead of the EPA, which is the Environmental Protection Agency, having its own guideline on healthcare waste management, which was developed in 2010, and then also the Ministry of Local Government and Rural Development having their own sanitation policy. The 3 ministries, the Ministry of Health with these ministries, have come together to work on all these 3 policies, put together one national guideline so that all these 3 agencies who are responsible for healthcare waste management in the country are speaking to one document, and then all stakeholders are working with one document. By this, we know that it will go a long way to help the healthcare waste management situation in the country. Again, we have developed standard operating procedures for healthcare waste management. First of all, at the national level, working with the Infection Prevention Control Unit of the Ghana Health Service, the EPA once more, and then the Ministry of Sanitation, Ministry of Water and Sanitation, to put together these SOPs, first of all at the national level for stakeholders of that level, and then also at the facility level, particularly these model facilities that we have chosen. So what are the benefits of this project to the facilities that have been selected? First of all, we are working with 5 facilities. As I mentioned earlier, the first 3 are going to receive non-incineration technologies for treatment of infectious and highly infectious healthcare waste. The first 2 are going to practice what we call a cluster system, which I explained earlier, that one central point will have non-incineration technology, and then facilities in that cluster would bring in their infectious waste for treatment. Then the third, I've mentioned 2, so 2 facilities will be doing the cluster system, and then one will be doing the on-site. That one is the health center, which is quite smaller and is in a small community. Then also we have added 2 other facilities. These facilities are already practicing some level of healthcare with waste management, which is acceptable. The first one is the Winneba Trauma Hospital. There you have a hydroclave installed there already by a Japanese project. So we have brought them on to support them as a model facility and then provide some logistics to them so to encourage them to continue to use the non-incineration technology and also serve as a good model facility for other facilities in the area who would want to practice it. And then there is the Okonfano Teaching Hospital, which is not using the non-incineration technology, but is using an incinerator, which is using the acceptable temperature, which is above 800. It's above 1,002 degrees Celsius to treat infectious waste. Then, so for the benefits, the 3 facilities would have the non-incineration technologies installed, and then all the 5 of them would have support from us introducing non-mercury containing devices. The non-mercury containing devices that we are going to introduce, like I mentioned earlier, is basically the BP pressure measurement apparatus and then the thermometer. Most of them are already using the digital thermometers, but like I mentioned, it's a bit difficult to totally phase out the sphygmanometers that is being used. A facility that is also selected in this project will also benefit from capacity building and training support to the health workers and then the environmental health officers in all of the selected facilities. This include trainers of trainers at the facility level, and then also the provision of logistics to train more other staff to be able to institute an acceptable healthcare waste management system in the facilities. Again, the project is going to supply personal protective clothing for healthcare waste management staff, which we have noticed is one of the main reasons why the healthcare waste management system in the facilities that we are working with is not up to standard. It's because they do not have the logistics to handle the waste, to separate the waste, to transport the waste and all that. We have, like I mentioned, these SOPs. The national one is for national level implementation, but for facilities that are part of the models, what we have also helped them, or we are in the process of doing currently, is that we are developing facility level standards of operation procedures and then also awareness creation materials for each of the facility. We want these documents to be facility specific because the levels of healthcare waste delivery in the facilities are different. So their needs will also be different. And then also all facilities that are part of this project will also be part of the Global Green Hospital initiatives to reduce their carbon print and also benefit from all the services that the Global Green Hospital is delivering to its members worldwide. Okay, so thank you very much for the presentation. I'll be here for questions if there are any. Lukman.
Thank you so much, Abena, for that very insightful presentation. I'll pass the ball now to Brian, and after which we'll take questions. Brian, you have roughly 50 minutes.
Yeah. Yeah, thank you very much for inviting me to do this short presentation. I'll try and leave out much of the issues that Abena has said, because I think the project is being run basically like all the same in terms of administration. It's a GF project, which is being implemented by the Ministry of Health in Zambia, and with UNDP and Healthcare Without Harm as other strategic partners, together with World Health Organization. Just as Abena said, it's a regional project which is done in 4 countries. I think I won't go into that. My presentation will be basically like on the background. I won't go much on project objectives because these have been highlighted. And then I'll just bring out the project implementation of activities that we've done in Zambia, and then some of the benefits that the pilot sites are likely to have, and then I'll conclude from that. Generally, Zambia has got quite a good number of healthcare facilities that range from health centers to the bigger hospitals. They actually tended to be the sources of healthcare waste. If you look at my slide, it was assessed in some time back, and that was found that out of the 1,674 healthcare facilities, they actually generate about 30 tons of infectious waste per day. Okay, so if you can see, this is quite a lot of healthcare waste that is generated. Just as in Ghana, much of this, or all of it, is actually treated through incineration. And most of these incinerators, they are below standards. Much of them are just ordinary ones. Some of them, they just do open air burning, and maybe just 1 or 2 that will be able to meet the actual standards. Maybe I'll just bring you to speed, just to show you some of the problem issues that we have on healthcare waste management. If you look at this picture, you find that the mode of transport is wrong. If you look at her hand here, she's putting on latex gloves. If you see this one, it doesn't even have proper protective shoes. And then you can also look at the highly infectious waste, which is stored in the lab. It's open. And then if you look at this incinerator here, you find that the storage is always delayed in terms of treatment. If you go further, this is like a final disposal site. You find that it's all chaotic with a lot of activities, other than recycling some materials. This is an open dump site for domestic, but since there is no proper segregation of healthcare waste, and then you find that much of it is also found at that end. Then what are the objectives of this project? Just as Abena said, is to implement the best environmental practices for the non-incineration and mercury-free technologies, to assist Zambia meet its Stockholm and Minamata Convention in order to eliminate the POPs and hopefully reduce the mercury or harmful diseases from the environment. But also to do with capacity building. The scope of the project that we've been focusing on is to improve and update the legislative and policy framework on healthcare waste management. Currently, Zambia is actually looking at 2 main acts, which is the Public Health Act, as well as the EMA, which is the Environmental Management Act. The Public Health Act did not include any issues to do with the healthcare waste management, and then this is the time that we have a window of opportunity to try and include such. Then the other area will be the actual healthcare waste management practices, which I think you saw from the picture that it's lacking in terms of segregation, collection, transport, storage, treatment, as well as disposal. The other one, of course, would be the main gist of the project, which is to move away from incineration and then introduce a non-incineration technologies by using of the autoclaves. And of course, the phasing down of mercury-containing devices that will be done, and capacity building. How has the project been implemented in Zambia? We first started by doing the assessment or conducting what we call as a baseline assessment to just try and ascertain the levels of healthcare waste management in the 5 healthcare facilities that are being piloted on the project. Though of late we've increased the numbers to 8. And then if you look at the preliminary results, you actually find that there were big gaps that were found in under policy and planning, that most of the facilities did not have much of this. There was also inadequacy in training, budgeting, waste in classification and segregation of healthcare waste, which was very patchy. Even small things like poster or signage, they were almost non-existent. Transport, as well as a delay in the storage of simple non-infectious waste, worse off with the infectious waste. This just shows the preliminary results of the baseline assessment, and if you look at it, you discover that the bigger hospitals like the University Teaching Hospital would almost be compared to the health center in terms of healthcare waste management. Those basically were the general observations, that all the incinerators that were assessed were not fully functioning, and none of the healthcare facilities had non-incineration facilities as a means to treat healthcare waste. What this simply means is that all waste generated from the healthcare facilities is actually incinerated. No record keeping. All the waste handlers were not provided with appropriate PPE. I think Abena did allude to lack of this. No training interventions, no vaccinations of waste handlers against hepatitis A and B, or even tetanus. I think I mentioned the lack of basic color coding. Now, what is it that the project will try and address on the Zambian side? We'll address on the policy and the regulatory framework to include the non-incineration technologies, because if you look at our main legislation, you find that we do not have non-incineration technologies embedded into the Public Health Act, as well as the Environmental Management Act, because as well as the Local Government Act, because these three, they actually form like the backbone of the healthcare waste management in Zambia. We also pilot non-incineration technologies in 3 healthcare facilities, where we've selected 3, and that one of these 3 will act as a cluster treatment facility, and then we'll have 2 that will act as the satellite. So the cluster one will be treating the waste that is being generated from there, and then the satellite will be able to bring their healthcare waste at one point. Then the other facilities will be like standalone in order to showcase the healthcare waste management as been provided.
Hello? I think we should just start with the questions because we're running out of time.
Very well. Hello, everybody. My name is Ruth Stringer, and I'm one of the regional expert team on this project. I'm going to be just helping today by organizing an answer and passing on some of the questions that have been put in the chat box. This one is from Tushma Kadi, who I believe is at Bongani Regional Hospital in South Africa. And he would like to ask Abena, is there involvement from the environmental health officers in the development of SOPs at the facility and national level, or was it only the infection control officers?
Okay, thank you, Ruth. And the question, forgive me, I am not getting your name. Yes, there was involvement of the environmental officer from all the model facilities. We are working with 5 facilities. Okay, so this is how we organized it. We brought all the stakeholders that are involved in it, like the Ministry of Sanitation and Water, the Ministry of Local Government, Rural Development, the Environmental Protection Agency, and then we brought the IPC, the National IPC Coordinator, and then the tutor who is responsible for healthcare waste management at the School of Hygiene. And then from the facilities, we brought together all the environmental health officers. And even in some facilities, we had the IPC coordinators, the occupational health and safety coordinators. So we brought them all together. And then together, we all developed the national SOP. And then also in that same meeting, we had the facilities break into groups and then develop their own SOPs, which relates to their specific service delivery. Then what we are currently doing is that these people are serving as focal points for us, and then they are going to discuss the facility level SOPs with the healthcare waste management committees that they have formed in their various facilities, and then review the work that we did in that group, and then they will give us feedback, and that is when the SOP will be finalized by the group that sat first to develop the draft. I hope I've answered you.
I think that's a great answer. It just really shows how much work has gone into this to be inclusive and make sure that all of the stakeholders' views are taken into account. And there's a lot of value in doing that, because if you've been part of creating the standards, then you'll be much happier to apply them than if they've simply appeared from, a bureaucrat's office somewhere. So another question that is, I think, can be one for you, Abena, which is about how you're practicing here. So now you're going to be phasing out the mercury-containing devices. And how are you going to be disposing of the condemned or phase-out devices? Burning, encapsulating, storing them, pit disposal? What's Ghana's plan?
Okay. So currently, what we have done, or we are doing, is that we first have worked with all the model facilities to have these, once we receive the non-incineration, the non-mercury containing devices, which will be supplied by the regional component. Once we receive that, we are going to provide these facilities with storage containers. Because of the nature of mercury and then the way it needs to be handled, the disposal will be taken over by the Environmental Protection Agency. So what we will do at the facility level is have the devices collected in a container and then properly stored, and then the regional EPA officers would have to go there, pick them, and then pay their expertise to work with another project that Jeff is also implementing with the EPA. We're also under the Minamata Convention. It's called MIA, Mercury Initial Assessment Project. So we are working in collaboration with this project for the EPA to lead in the disposal of the mercury-containing devices that we are going to collect from the facility.
Thank you, Abena. That's very helpful. I'm not sure everybody will have heard about this project to implement the Minamata Convention. It's really important because of the fact that you can't destroy mercury. Okay, next question. This one is more general and less directed to the project. Are there standards for pits for the use of the center and sharps?
What I know is that the infection prevention control, the National Policy for Infection Prevention and Control has specifications on how to dig the placenta pit, how to maintain it, and then how to, even what to put in there, because it is not all pathological waste that should go into the placenta pit. So that's what I know, that the National Infection Prevention and Control Policy has some specifications on how to handle that.
I see. So, but your national policy is still in development, isn't it? So it's not public just yet.
Yes, please.
So that is something that could be shared either via Connect or via the GEF project website.
Okay.
I can also add that there are specifications in the World Health Organization's Blue Book, which is the guidelines on safe management of healthcare waste. So if anyone cannot access either of those, they can ask a question to Lukman via Connect, and he will be able to point you in the right direction. The other general question that's coming from Tush is that if there are other methods of healthcare waste management that are used except incineration, and how are these technologies being rolled out regionally or nationally? I think that's really what this whole project is about, isn't it?
It's about, yes. Yes, that is what this whole project is about. Like I mentioned in my presentation, until very recently, all that we had in terms of healthcare waste management was incineration of the waste. And in very rural areas, what happens there is sometimes open burning. But now what is happening is with the awareness creation of the effects of open burning and then incineration, new facilities that the government is developing are installing non-incineration technologies. And then, for instance, for Komfanoti Teaching Hospital, which is a very big hospital, they are still doing incineration, but at the accepted temperature, which is above 200 degrees Celsius. And then also we currently have private sector participation in the healthcare waste management. There is a project that a Turkish company is doing with a local healthcare waste manager. It's called Zumpak. Zumpak has installed a giant hydroclave in the region of Accra, where it is looking at implementing a central treatment facility where almost all facilities in Accra can bring their infectious waste for treatment. So to answer that question, what I would say is that until recently, we didn't have a lot. All we had was incineration, but gradually the non-incineration technologies are springing up. And then for facilities who are still embracing the incineration, awareness creation and sensitization is going on for them to adopt the best environmental standards for installing such incinerators. For example, the military hospital in Ghana, 37 military hospital, is initially was not part of the project. It was part of the pre-assessed hospitals. And then during the budget readings for this year, we learned that government intends to build incinerators in most of the garrisons. So what the discussions that are ongoing with them now is that we have developed a policy brief and then a project brief, and then we have first met with the managers of the facility, and even tomorrow we are having a meeting with them on a decision to shift from incineration of waste as a treatment option to a non-incineration treatment option, or if they, due to the nature of the service delivery at the facility, they still want to opt for incineration, then they would have to go for the best environmental practices, and then those that have been best international standards for incineration. So currently that is what we are doing.
Thank you, that's very helpful. You'll have seen in the chat box I've just put up the reference for the World Health Organization's Blue Book. That gives, that's a very useful one about general waste management technologies. I will follow that in a moment with the reference to the UN Environment Programme's Compendium of Technologies for treatment and disposal of healthcare waste, which gives a lot of very interesting detail. And then finally, with the reference to the URL for Healthcare Without Harm's own database of suppliers of healthcare waste treatment technologies. That's all the non-incineration stuff. So those will be useful for you if you want to learn and read more about this. So thank you very much to Abena for sharing her knowledge with us. And I am going to hand back now to Lukman to wrap up.
Thank you, Abena, for answering all of those questions. I'm sure if Brian was around, it would have been a lot easier, but thank you for sharing your knowledge with us. I think this is the first in a series of webinars regarding this project, and I'm sure by the next time we have the next webinar, we will be able to share more information regarding this project. But I can assure you that we are all excited about it in Africa, because this is a huge opportunity for us to phase out medical waste incinerators. This is a huge problem for us, especially with communities that are surrounding some of these incinerators. And we look forward to results from Zambia, from Madagascar, from Tanzania, and also from Ghana. And we hope that this will be an opportunity and a huge resource for us in the rest of Africa. Thank you all for participating in this webinar. And also, I just want to remind everyone that this webinar is actually recorded and it's available on Connect. You can download it on Connect. Also, you'll be getting certificates of participation in this webinar, and I'm sure Sonia will be sending out the certificates very soon. So thank you all for participating. Thank you, Sonia, Ruth, Ale, for facilitating the session. And we look forward to having everyone soon. Thank you so much. Bye-bye.